Thank you very much for everybody for coming. I am in the Department of Neurosurgery, like Elizabeth said. I'm currently the chief of the spinal neurosurgery section. I've been here about 3 years. And the goal today is to tell you kind of the essential things we need to know about back pain. Before I start, can I have like a raise of hands? How many people in the room have had episodes of back pain? Okay. I want to start with a little story which I grabbed off the internet. This is a patient that described her experience with back pain on the internet. And she started with, I never had back problems, and then one Saturday I bent over to scoop out the cat box, and when I tried to straighten up, I could hardly do it. She goes on to say, some people can hardly move, but I could stand and sit, although it hurt. It felt a lot better to lie on the floor, but I could do things with friends and around the house. My husband has back pain and knows what to do. I put ice on it right away, took some ibuprofen, slept that night on my side with a pillow between my legs. Lorna got active the next day, taking short walks as recommended. Although her back still hurt, she went to work on Monday as usual, and to her surprise, the back hurt all week. I thought, okay, it would hurt for a day or two, and that's it. But it lasted a lot longer, and it took about 3 weeks. But she stayed patient, and the pain and stiffness left. Things are back to normal almost. Now she thinks about how she moves. She no longer bends at the waist to empty the cat litter, and she now squats, bending at the knees to pick up things up. So that kind of story summarizes essentially what I want to talk about today, and kind of goes over the kinds of things you can do to prevent back pain. Just a few facts about back pain. It is the second most common reason for visits to the doctor. Approximately 1/4 of the U.S. population reported having at least one whole day of back pain in the past 3 months, and 7.6% do experience at least a very severe episode within any 1 year period. And as can be evidenced from the little poll we just took, almost everybody in this room has had an episode of back pain. So what I want to describe today is kind of some basic facts, then go over symptoms of back pain, the typical traditional symptoms. I want to touch a little bit on the red flags, when to see the doctor, and then go over the causes, risk factors. I want to describe a few of the management options, and then prevention, and then where to go for help. So the typical symptoms, and we've all experienced some back pain, is muscle aching in the back. Often there's shooting or stabbing pain. The pain may radiate to the leg, one leg or both legs. Typically, there is a loss of flexibility of the spine or range of motion, because this may make the pain worse. There may be inability to stand up straight. The pain may be sharp or dull or burning. It may be constant or on and off, and often is affected by body position. There may be associated symptoms, and these are the most common symptoms that may be associated. There may be weakness of the legs, numbness of the skin, tingling or paresthesias. In severe cases, there may be difficulty walking, bowel or bladder disturbances, erectile dysfunction, and sometimes back pain is associated with systemic disorders like infection or cancer, in which case there may be weight loss or fever. Some of the red flags, if you have back pain and you have bowel or bladder problems, or have associated pain or throbbing sensations in the belly, or fevers. Generally, that usually means a serious problem, and it's probably best to go to an urgent care center or an emergency room. Also, if it's very obvious the cause of the back pain, that it was a blow or a trauma to the back, it's probably important to seek immediate care. Another reason you should consider to see a doctor if you have back pain is if the pain is constant or intense, especially at night. The reason doctors usually ask whether the pain goes away at night is because cancer pain typically is worse at night and typically doesn't go away when you lie down at night. And that's why frequently when you go to the doctor, one of the first things they're going to ask you is your pain worse during the day or at night, and does it go away? So that's not always an ominous sign, but certainly if you have that, you want to go see a doctor and discuss with the doctor. Another reason is if the pain goes down one or both legs, and especially below the knee, that sometimes would suggest that there may be nerve compression or nerve impingement, and so you need to see a doctor to try to rule that out. Along the same lines, nerve compression may cause weakness, numbness, tingling in one or both legs. If the back pain has been accompanied by unexplained weight loss, if you're eating normally but you're losing weight and you start having back pain, that's something that is of concern and you need to see a doctor right away. And also if there's redness or swelling of the back, that would suggest perhaps there is an underlying infection of the bone, and you need to see the doctor right away. Next, I want to talk about risk factors for back pain. What are some of the risk factors? And so I divide the risk factors into factors that are non-modifiable. You can't change it even if you tried. And then modifiable risk factors, and then treatable risk factors. So the non-modifiable risk factors is more common in middle or older people. We all get degenerative changes in the spine, and therefore, as you all get older, you're more likely to experience episodes of back pain. It's more common in males, in patients with a family history of back pain. History of previous back injury puts you at risk. Pregnancy because of the added stress on the spine. History of compression fractures, previous back surgery, and history of spine problems since birth, like scoliosis. Here are the modifiable risk factors. Lack of regular exercise. If you have a mechanical stress job that involves heavy lifting, prolonged sitting, bending or twisting, constant vibration, using a jackhammer, or driving a heavy equipment, that puts you at risk for back pain. Sports like golf, a lot of golfers have back pain due to the twisting and bending motions of the spine. Smoking, overweight, poor posture, and stress and emotional distress have all been associated with increased incidence of back pain. Most of these are modifiable. And then the treatable risk factors include depression. People with depression have an increased incidence of back pain, and it's always hard to figure out which came first, the back pain followed by the depression, or the depression first. But it seems to be a depression may be independently related to the back pain as a precursor of the back pain, not as a consequence of the back pain in a subset of patients. Steroid-induced osteoporosis. This is typically patients, for example, that have rheumatoid arthritis or have COPD and are on steroids, chronic steroids. Steroids weaken the bones, and therefore they're likely to get osteoporotic fractures and back pain as a result. Chronic coughing, and suddenly abdominal and pelvic disease like uterine fibroids or anything in the pelvis can present as back pain because they're contiguous to each other. The perhaps the most important cause of back pain is a muscle or ligament strain, usually from either heavy lifting. This is how most people present. Either they lift a heavy object or they try to bend over like the story I presented, and they feel a strain in the back. And then usually that's from just a muscle strain, and we'll talk about the management of that, given that this is the most common reason, usually self-limited. But other causes of back pain include degenerative disc disease, for example, bulging discs, disc protrusions, degenerative arthritis, and I'm going to show a picture of this later. And then less common is the scoliosis, trauma, tumor, abdominal pelvic disorders, and then systemic problems, cancer, infection. Okay, so the three most important causes: muscle strain, second probably the degenerative disc disease with the bulging discs and the disc protrusions. Third is the arthritis, where you have bony ingrowth. It narrows the spinal canal. The nerves don't have enough room, and that condition is called spinal stenosis. That means you have bony overgrowth. The spine canal becomes very narrow. There's not much room for the nerves, and it presents as pain in the legs when you're walking. So this is a picture of a normal spine here. You have the vertebrae in yellow, and then in between the vertebrae is the disc, which is kind of like rubber, it's like a cushion, shock absorber. And on the sides is the nerve roots. And as we age, the discs begin to degenerate, they become harder. They no longer act like shock absorbers. They lose their height and water content. And the result of that is that the nerve canals, or the nerves are coming out, become narrow, and there's not a lot of room for the nerves, and that's how you end up getting the symptoms of pain running down the legs when there's not enough room for the nerves to be free to move around.
What about annular tears? We see those on our MRI reports now.
Yeah.
Annular tears were causing pain?
Yeah, so the disc, annular tears is like the first step in the degeneration of the disc. And so often on an MRI, you will see a disc like this that begins to lose the water content, and you see a high signal on the MRI suggesting that the disc is beginning to break down. And that correlates with increased incidence of back pain. And so that's an early process, and this over here is more like the late process, where now the disc is degenerative, the disc height is decreased, and the water content is gone. But this is kind of the reason for one of the most common reasons is the pain often is either coming from the disc itself or coming from the joints. These are the facets, what we call the facet joints, and they build up inflammation over time. And when you move around, you put pressure on these joints, and they have little pain fibers in them. So if you move around and you put more loading on the joints, then the pain fibers activate, and then you feel the pain. Okay, so those are the one of the most common reasons why we see in the clinic. The figure here shows you the disc protrusion, which is the other common cause of problems, not necessarily as a result of aging. This can happen in, even in young people. So here you have a side view of the spine, and you see a disc that's kind of protruding out and pushing on the nerve roots. And this is the standard herniated disc that often requires surgical consultation to decide if surgery is necessary. This figure here gives an example of skeletal abnormalities like scoliosis. This is a patient with a curvature of the spine, and that's another very common cause of back pain. So now I want to switch gears a little bit and talk about how do you manage back pain. So in order to do this, you have to understand the difference between acute pain and chronic pain. In general, any pain that lasts less than 3 months is considered acute, and any pain that lasts more than 3 months is chronic. The reason it's important to separate them out this way is because most people with acute pain would recover. Chronic pain is an ongoing problem and requires more intensive treatment. So as I mentioned before, one of the most common causes of the acute pain is the muscle strain. This is a little bit of an injury just to the muscle, but it can be associated with muscle spasms, and it's very painful. The pain is usually sharp. The muscles feel very tight. And so often patients would think there's something really, really wrong. But generally, most pain of this nature will resolve in 3 to 6 weeks, and nothing needs to be done other than a little bit of ice, heat pads. So the important thing with this pain, if you're getting back pain for the first time, you have to understand that most likely the pain will go away. It may take some time, up to 3 to 6 weeks, but it will go away. And self-care is really all you need. You can use ice, you can use heat, you can use both, whichever one feels best to you. You want to stay as active as you can. Used to be they would say, rest, lie in bed for 3 days. No, the new recommendations is walk around, be active, as long as it's comfortable for you. Don't rest up and lie in bed for like a week, and your healing would be much faster. You can use over-the-counter medications. This can be Tylenol or ibuprofen. They're all safe if used in a short period. Unfortunately, a subset of patients will continue to have recurrent pain. Either the pain comes back or they re-injure themselves. And that's when the pain becomes chronic. And that has to be managed essentially like you would manage diabetes, or it's a chronic problem that you would live essentially with the rest of your life. Some periods would be okay. So the management of that is to be able to get into a situation where you have pain, but it's tolerable most of the time. It's like a 1 or 2 on a scale of 10, 1 to 10, and you can handle it, and you can still function and work and be okay. So if you have chronic pain, what should you do? There are many options out there. If you do an internet search, you're going to come up with a very confusing array of things, from laser spine surgery to, So I think that the easiest thing is a comprehensive rehab program of some sort. And it's been shown that that's one of the best ways. So this is like a holistic approach where they cover all different angles, physical therapy, nerve injections, everything in one area. And it's been shown that that's probably your best bet for finding the right combination of treatments. And the right combination is different for everybody. For you and I, it's going to be different, And so we can't prescribe one thing for one size for everybody. You have to try different things to find which one works best. Some people respond to acupuncture. Okay, so some comprehensive rehab programs would have that available as an option. The problem is you don't know which people are going to respond. Another thing that's very helpful is biofeedback, which is kind of a way to become more mindful of your body and how it's reacting. And it's a good kind of stress reliever. Along the same lines is cognitive behavioral therapy, which teaches how to cope with the pain and teaches you stress management skills. A subset of people will benefit from seeing a chiropractor. And, you know, traditional medical school, they don't really, you know, kind of tell you chiropractor does anything beneficial, you know. But I've seen a lot of patients with back pain that, you know, would swear by a chiropractor that they've had a lot of benefits from visiting. So I don't tell patients not to do that. If it's helping them, I encourage them to continue it. Massage can be very helpful. The muscles, especially people doing a lot of heavy work and repetitive trauma to the back muscles, you know, massage can improve the blood flow, allow them to relax. So it's most comprehensive rehab programs would include a component of that. And yoga also has been shown to help some patients with back pain. So these are the medications. You can have Tylenol, NSAIDs. Muscle relaxants are good, but you just have to realize that it can cause some dizziness and make you very sleepy. And so there are a few of them. One of them is Flexeril. Another one is called Robaxin. Soma is the third one. You know, so you have to, sometimes if you don't respond to one, you can try another one, and your body may agree a little bit more with a different one. Narcotics like Vicodin, oxycodone, OxyContin, you know, those can be done if it's on a very short-term basis, obviously under the supervision of your doctor. But generally, they don't work well for back pain because the pain is usually inflammatory, and these are not inflammatory medications. So, you know, often drug seekers would end up getting a lot of prescription. These days, the state is tracking the number of medications, narcotics that physicians prescribe. So hopefully the abuse of these medications will go down. But they don't really help, and people just keep taking more and more. But you know, all you probably need is those over there. Physical therapy is really the cornerstone of treatment of most rehab programs. A good physical therapy, they can advise us to the heat, ultrasound. They can use electrical stimulation techniques, muscle release. And then once the pain resolves, they can give you exercises that you can do at home to increase your flexibility and strengthen the back and abdominal muscles. So what happens when you have acute back pain, you try all the things, you put ice on it, you do all you take Tylenol, ibuprofen, but it's not working. Or what if you have some of the associated symptoms that I talked about, pain in the leg, numbness in the leg, bowel bladder functions? Then obviously the next thing you want to do is call up the doctor. And this slide kind of lists the kinds of things you should be thinking about asking your doctor when you see the doctor. You obviously want to find out what the most likely cause of the back pain is. You know, it's amazing to me how many patients come to see me and they don't ask that. You know, they just, you know, but it's important to really ask the doctor, what do you think is the cause of my pain, the most likely causes, you know, and get a very good clarification of that. Do I need any diagnostic tests? You know, you may not need diagnostic tests. You know, if the doctor tells you do, you can ask, why do I need these tests? You know, because you could get into a situation where some doctors just knee-jerk would order an MRI scan the first time they see you, and you may not necessarily need that. Okay, what treatment approach do you recommend? You know, is it just bed rests? Now, if you don't know, and if you don't know that the current recommendation is to be active and not bed rest, and a doctor tells you to just do bed rest, then you can say, well, what about the recommendation these days that you really should be active, you know? So you have to be informed, because not every doctor, sad to say, is up to date on the latest recommendations. Okay, so the knee-jerk thing is a doctor might say, well, why don't you rest for a week? Take 1 week off work and lie in bed and watch TV or something, you know. But that's actually, you don't want to do that. You want to be active, walk around, you know, keep walking around the neighborhood. If you know, And then the last thing is, if you happen to have other medical conditions, then you want to know, how is this going to impact these other conditions that I have? You may have Parkinson's disease, you may have other things, so you need to ask, these new medications, how are they going to impact my current conditions? Then other questions that are very helpful is, how long will I need treatment? What self-care measures can I do? And is there anything else I can do to prevent this problem in the future? In preparing to see the doctor, you want to organize, you want to be organized. So write down all your personal information, including any mental or emotional stresses in your life. Make a good list of your medical history, any new medications that you're taking, and then try to remember any recent back injuries that you may have had. And then when you visit a doctor, it's always nice to bring a family member or friend, because you may forget some questions that you want to ask, and so it's nice to bring someone else, and they can also perhaps help remind you of certain things that a doctor mentioned that you may easily overlook. It's good to write down your questions in advance, and that way you don't forget something important that you want to ask. So you see the doctor, what will the doctor do? If you come to my office, what would I do? The first thing I would do is review your medical history, going over, do you have a family history of back pain? Do you have a history of cancer? Do you have a history of abdominal or pelvic disease? Have you had back surgery before? So I take a very detailed history. Are you on steroid medications? We use this very systematic approach. How long, and then we talk about how long has the pain been? Where is it? Is it affected by body position? Is it worse at night? Is it worse with movement? Very detailed, and your answers may point me in one or different direction. I do a detailed physical exam, make sure there's no curvatures of the spine or back. Make sure you're walking straight, your leg length is okay, you don't have hip or knee problems. So we do a detailed physical exam. I make sure there's no redness at the back. There's no signs of infection. I look at your vital signs, make sure you're breathing normally. You're not. I check your pain levels. Do you appear to be in a lot of pain, or are you just comfortable? So we look at all of that to give us an idea of the severity of the problem. I do a detailed neurological exam. I'm looking for, is there weakness? Is there numbness? If there's numbness, is it in one nerve distribution or in multiple nerve distributions? Is there a bowel and bladder problem? I'm looking for signs that this is a serious problem and I need to do something that day, or something I can take my time to work out. Diagnostic tests, your doctor may prescribe a diagnostic test depending on where you are in the complaint. So if this is your first week, you may not do anything, but if you're coming to see me and you've already had physical therapy, you've already had nerve injections, and you're still having pain, that would tell me there's something else going on. Maybe I need to get an MRI scan. Okay, if you're telling me, oh, I was playing baseball, or I was hit, I lifted a heavy object, that all points to, whether I should get a diagnostic imaging right away, And the diagnostic test that you want to perform is usually either an X-ray or an MRI scan. Usually we don't start with X-rays unless we suspect some kind of trauma, because they're very low yield. They're not going to show the nerve. So if I really think there is a possibility of a nerve compression, usually I would go with an MRI scan. Now the current recommendations for getting an MRI scan is failure of non-operative management for 6 to 12 weeks. Insurance companies will not approve an MRI scan unless you've failed physical therapy, you've failed basic non-surgical management. You've tried ice, heat, physical therapy, maybe some chiropractor, maybe some injections. And often they won't get an MRI unless the pain is going down the legs. Because remember, the MRI is looking for evidence of nerve compression. And if you just pure back pain, then the big question is what's the yield? And, surgeons would argue you can get cure back pain from annular tears like you were asking. And therefore, sometimes we have to argue with insurance companies to say, okay, patient doesn't have, pain in the legs, but there's a possibility the pain could be from an annular tear, in which case they would just have only back pain. And often they won't approve the MRI for the primary care doctor, but if I call them, then they would approve it, simply because I'm the treating surgeon. So I've had many situations where primary family physicians, and I don't know if there's a family physician in the audience, they will call me, send a patient to me and say, we can't get approval for the MRI. But when I call, I explain, look, there's a subset of patients that have degenerative disc without leg symptoms, and we need to really get an MRI to decide. The doctor, depending on who they are, if they are primary care doctor, they may refer you to a physiatrist, which is a PM&R doctor, a physical medicine and rehab specialist. PM&R doctors are the experts in everything, the physical therapies, all the non-operative management. They're the best people who know the best about those types. The other people they can refer you to a spine center. And the spine center typically will have PM&R docs, surgeons, pain management people in the center. They may also just refer you to a physical therapist. And of course, they can send you to the surgeon. That is kind of dependent on your primary care's preference. Some have a group of physicians they work with as the next step in the process. And so at the end, I'm going to talk about our spine program, what we have, and we work with all of these to make the process very efficient for patients. We're trying to create a one-stop shopping where if a patient comes, they can see all the key people on the same day, and not be a situation where I see the patient, then I try to get an appointment 4 weeks later for a physiatrist, and then that takes another 6 weeks to see a pain clinic, and the patient comes back to me after another 4 weeks. What we want to do is create a center where the patient, if I see the patient and I said, I don't think you need surgery, but I want you to see a physiatrist, that can occur in the same day. And if he says, I think we want to do some injections of your joints or whatever, discussion can occur on the same day. I think it's a much more multidisciplinary, efficient process for patients. So often when I see a patient and it's a chronic pain situation, it's been going on for 2 years or 6 months, often I can't tell whether it's 1 or 2 nerve roots. Maybe it's the L4 nerve. So let's say I get an MRI. There's 2 discs that are degenerative, the L3-4 and L4-5. I examine the patient and it's not clear. It seems like maybe the symptoms are in the L5 nerve root distribution, but it's not very clear cut. Maybe there's a little bit of L4. We face that frequently, and what we do then is we will, for example, ask the pain specialist to inject the L5 nerve roots. And if that takes away a lot of the symptoms, then we'll say, okay, perhaps this is the problem. The L5 is the main problem. So frequently we do this. Often though, the pain specialist would do what's called epidural steroid injections. And the reason for that is that they think there is inflammation that's built up around the nerve roots, multiple nerve roots. So if you apply steroids, which has anti-inflammatory properties, then it can wash away all the inflammation and kind of get you back to your baseline. And that's the rationale for the epidural steroid injections. It works about, on and off. It's very unpredictable. A lot of surgeons don't believe in it. I'm not even sure all the pain, but it is reimbursed by Medicare. And so doctors get paid if they do it, and that's part of why perhaps it's still there. But it's not clear-cut that it makes a huge difference. But I like to use it more as a diagnostic process, as a selective nerve roots. If I'm trying to sort out L4 versus L5, then I can inject the L5, and if it doesn't really change it, but the L4 does, then that tells me maybe that's the problem. We can also do what's called facet injections or sacroiliac joints. And the facet injections are joints in the back. Between each spinal segment, there are joints, just like you have knee joints and elbow joints and hand joints. You can build inflammation in these joints. And they have pain fibers in them. And you can inject and numb the pain fibers. And so if we inject the L4-5 facet joints and you get benefits, then that tells us, yes, that's a big component of your pain, and we can treat that. Sacroiliac joint is estimated that about 20 to 30% of back pain in the adult population is due to sacroiliac SI joint problems. And so to confirm that, you basically inject anesthetic into the joint. And if it takes away a lot of the pain, then that's the problem. And you can then prescribe specific physical therapy for that. You can also do what's called radiofrequency. For both the facet and the sacroiliac joints, you can do what's called a radiofrequency rhizotomy, where you heat up the pain fibers to destroy them. The pain fibers don't do anything other than transmit pain, so you can heat them up and just basically burn them up. And there are no side effects. There's no loss of sensory or motor function. They're just pain there for transmission of pain. And so if we inject the facet or the sacroiliac and it works out, often we'll refer you to the pain clinic to do a radiofrequency procedure where you get rid of those pain fibers. In a subset of people, all of that doesn't work. So let me just summarize. You've tried ice packing, you've tried all the usual things, physical therapy, you've done all of that. You've seen the surgeon, they've had you go inject your SI joints, you've injected your facet joints, you've had epidural steroids, you're still having problems. And now the surgeon gets information from the pain clinic, and now he thinks it's L4-5 is the problem. I need to go operate and free up the nerves in that area. Usually means you have pain that's going into the leg. You know, you may have some muscle weakness, tingling bladder problems, or you have some structural abnormalities that can be corrected with surgery. And I'm going to talk about a couple of those. But unfortunately, in a subset of patients, they will need surgery. But having said that, few people ever need surgery for back pain. When you look at a big scheme of things, the number of people with back pain, only a very tiny number ultimately will need surgery. This, I think we've gone over this. There are two additional studies that you want to be aware of. One is the bone scan, and normally we do that when we suspect osteoporotic compression fractures or tumor. Bone scan is a nuclear medicine study where it would light up where there's a lot of bone inflammation. And so we can look at a spine and then look at hot spots in the spine. And often regular x-rays would not show a fracture, but the bone scan will show that. The doctor sometimes would order nerve conduction studies. This is kind of along the lines of the differentiating between an L4 and L5 problem. The nerve conduction study is a study that checks conduction in the nerve muscles, and it will tell you which nerve root is being compressed. Is it the L4 or L5, or is it S1 nerve? So we use that as an adjunctive study in addition to the MRI scan. So let me just begin to talk about the prevention. How do you prevent yourself from having back problems? First, you have to learn how to stand, and you have to maintain a neutral pelvic position. If you have to stand for long periods of time, it's best to alternate placing your foot on a footstool to take pressure off the back. So a lot of back is related to poor posture, so making sure you stand up straight is very helpful. Along the same lines, if you have a job that requires prolonged sitting, then make sure you have good lower back support, armrest, swivel base. you can consider placing a pillow or roll towel in the small of the back to maintain the normal curvature of the back and keep your knees and hips level. It's important to change your position frequently, almost every half hour. If you have back problems and you're flying on an airplane, make sure every half hour you get up and walk around a little bit. If you have to drive 6 hours, make sure every half hour you stop and walk around a little bit. Lifting, the legs do the work. You straight up and down. Keep your back straight, bend at the knees. And the load, of course, has to be, you don't want to be out there lifting a heavy object. You got to keep it close to your body. Obviously, you don't want to lift and twist. That's not good. And lift and partner. These are all common sense things that, exercise is very helpful. But you don't want to strain or jolt the back. Swimming and walking are probably the best exercises if you have back pain. Swimming are probably the best. Water-based exercises. But you can certainly walk, and elliptical machines are very helpful. And of course, you want to try to maintain a heavy weight, healthy weight. The one exercise that's really also very good, if you don't have back pain already, abdominal strengthening exercises, what we call the core muscles. Strengthening the core muscles in the back is the best thing you can do to protect yourself against future back pain. So, and then of course things like stretching, daily stretching, to improve the flexibility. This is where things like yoga may be very helpful as a preventive measure. If you look at the statistics, almost all of us would have back pain. So it's one of those things you can almost not avoid it, but you can certainly protect yourself by doing some of these things on a regular basis, and aerobic exercise to keep things toned up. The other benefits of exercise is if you have back pain, I think the recovery process is better if you're somebody who exercises on a regular basis. Then so if you look at the athletes, you look at Peyton Manning, the Denver Broncos quarterback. I mean, he's had like 4 neck operations, but if you watch him play against Kansas last Sunday, you'd never have guessed that this guy's had, So I think the fact that these guys are in top physical shape allows them to recover even from spine surgery and perform at really high elite levels. What about special mattress, shoes, insert back supports, furniture, things like that? There is really no evidence. I mean, it's one of those things where if it feels comfortable to you, then you can use it. So there's a lot of consumer things on the internet that people buy claiming it will help your back pain, but there's really no evidence. So if a shoe feels comfortable, then maybe you can use it, but just don't spend too much money on some of these things. They can cost $500 shoes and $1,000 mattress. So as I wrap up here, this is our website. As I mentioned, we're developing the one-stop shopping model where you can call in, you can be seen the same day, and you'll be seen by all the key people, the physical therapist, the physiatrist, the pain clinic people, all on the same day, as well as the surgeon. And we can let you know, do you need surgery or not? Get all that in the same day. This would be, you can call the number listed. These are our staff. All of us treat spine. And we have the rehab division within our division. All the physiatrists are within the Department of Neurosurgery. It's kind of a very interesting, unique setup. I think is the only one that I know of around the country where all the 10 PM&R physiatrists are all within the Department of Neurosurgery. So it makes it a very efficient setup for seeing patients. And you have the appointments there. Often we work with medical doctors, often patients need reassurance that they don't need surgery, and so we can provide that consultation, just to reassure them that you're okay, you don't need any surgery, you're going to do okay. So in conclusion, to summarize, we talked about back pain being a very common condition. Most patients do not need surgery. We discussed the red flags that you have to be aware of. Leg pain, numbness, bowel and bladder symptoms, weight loss. Those are some of the main and weakness of the legs. We went over the different non-surgical management options, particularly for chronic pain. And then we went over the simple common sense things that you can do to prevent pain in the future. And then I hope that I also outlined for you the criteria for surgery. Usually failure of 6 to 12 weeks of non-operative care, evidence of structural abnormalities, nerve compression, spinal instability. What I haven't talked about today is the types of surgery that you can perform. There's a whole new technologies. Surgery can be performed a lot more safer. There are several different options. I can certainly do another lunch and learn later to talk about surgery. So if you have a disc, what are your options? And if everybody agrees you need surgery, what are the options? You can do an open surgery, or you can do what we call a minimally invasive surgery through tubes. You can have a bigger incision or a smaller incision. If you need spinal fusion, where you need screws and rods, what should be done, or what are the alternatives? The alternative is artificial disc. Now we have artificial disc. This maintains the normal motion. The fusion fuses the spine, restricts motion. Now we have artificial disc. So at a later date, we can talk about some of that. If you have spine tumor, spine cancer, there are new ways of treating it now. We have the CyberKnife. Louisville, University of Louisville has the only CyberKnife in this area. And that affects the type of surgery that we can do. It limits the morbidity of surgery because we can use the CyberKnife to control the tumor, and we don't have to take the whole tumor out because it's a totally morbid procedure. So there are a lot of new technologies and new ways, and the way we treated spine conditions 10 years ago is very different from the way we treat it now. And I can come back and update you on some of the newer things that we're doing, and some of the decision processes that goes into whether, if you have a cervical disc problem, whether you should pick the fusion or the artificial disc. Okay, so I'll stop there. I can take any questions regarding any of this.
What do you feel about using discograms to make diagnoses of disc problems?
I don't like them. Before I came from Stanford University, where I worked with the chairman of the orthopedics there. His name is Eugene Kuragi, and he had published a lot on discograms, and he did even studies where he injected normal people with no history of back pain with discograms and created the same pain that you would see, So his conclusion, if you read his work, is that discograms doesn't work. By the way, discogram is a way of testing the hypothesis that the back pain is coming from the disc. So when someone has back pain and there's no obvious nerve root compression, then the question is, where is the pain coming from? But remember, I showed you the film on the degenerative disc. So you could have degenerative disc. I also mentioned to you there's facet joints and SI joints. And so then the question is, what is the pain coming from the facet or the SI or the disc? And so the discogram is, okay, if you believe it's coming from the disc, then if I go in with a balloon or a needle and I increase the pressure inside the disc, then perhaps, and the patient says, oh yeah, that's my pain, that's exactly my pain, then that provides evidence that that disc is causing pain, in which case the treatment for that is we go in and take out all the disc and either do a fusion, put screws and rods because you're taking out a disc, or put in an artificial disc. What the new school of thinking is, if a disc is degenerative, you know it's degenerative. You can tell from the MRI. The height of the disc is low. There's changes around the bone, the end plate modic, what neuroradiologists call modic changes. And a lot of surgeons now feel if you have those things and you don't have, you've injected your facet joints, you've injected your SI joints, you've tried physical therapy, you've done everything, and nothing works. The only thing that's left is the disc. Okay, and the patient says, I have 10 out of 10 pain. I've done everything, physical therapy. Now what do we do? And the MRI shows clearly one level of disc that is degenerative. Everything else looks fine. Then some surgeons will go in and take that disc out. And then the decision is, do you put in a bone graft or do you put in an artificial disc? Yep.
I had started about 5 weeks ago and used an anti-inflammatory and started therapy. But my question is, I had numbness on my legs, which kind of went away, but I still have numbness on my arms, and especially hands, and especially leg. And I was wondering if it is also pretty much like related to the same thing.
So numbness in the arms is usually, you have to sort it out. Is it coming from the neck, or is it coming from a compression in the arms? So, or is it what we call peripheral neuropathy? So assuming you come to me and say, okay, you have some numbness in the arms and some neck pain, we'll have to do a full medical history. Is the numbness, do you feel is starting from neck shooting down? Is there pain in the same areas? So we have to sort all of that out. The differential diagnosis, the causes of neck and arm is a little bit different than in the leg. In the arm, you begin to think about, is it carpal tunnel? You know, are you someone that does a lot of repetitive motion, typing and things? So is it a compression here? There is an ulnar nerve here that can be compressed here. So we have to decide, is this a compression from here or not? And then there's what we call brachial plexus here. So we need to sort out. And then finally, is it something at the roots of the spine, and nerve roots? So we have to sort all of that out.
Yeah, I kind of started at the same time. I started hearing my back pain, so I was back and goes through to the neck a little bit.
It's probably not related. I can talk to you a little bit more about what might be going on, but chances are the two are not related. There's also, I didn't talk about peripheral neuropathy. That's an inflammation of that you see. So without knowing anything about you, whether you have a history of diabetes, where but the short answer is probably not related. Probably different issues.
Just bad luck.
Yeah. Okay.